Le cancer du sein HER2 positif est l'un des plus agressifs. Depuis l'introduction des thérapies ciblant le récepteur HER2, les chances de guérison se sont considérablement améliorées. Alors comment exploiter au mieux ces médicaments pour progressivement se passer de chimiothérapie? C'est un cheminement de 17 années que s'apprête à nous retracer la prochaine oratrice. Monsieur le Président, je vous laisse introduire ce membre de la compagnie.
Thank you very much. It's a great honor and pleasure to me to introduce Professor Martine PICCART, member of our academy. She is a professor of oncology at the University Libre de Bruxelles and the scientific director of the Jules Bordet Institute in Brussels. She has been president of the European Cancer Organization, the European Organization for Research and Treatment of Cancer, EORTC, the European Society for Medical Oncology. She was on the board of ASCO, as well as on the board of the American Association for Cancer Research. And she was elected fellow of the AACR Academy in 2013. She's a leader in the field of cancer worldwide. She has catalyzed international research collaborations and most notably, together with Professor Aaron Goldhirsch, created the Breast International Group, DIG 1996, which today unites 56 academic breast cancer research groups from all over the world. For this research advances and international activity, she received a number of prestigious international awards, and she authored 670 publications in peer-reviewed journals. So without further ado, thank you very much for your presence today.
Monsieur le Président, Monsieur le Secrétaire perpétuel, chers collègues, bonjour. And I'm going to switch to English. So my task today is to convince you that some patients with a particular breast cancer subtype that we call HER2 positive breast cancer will be cured one day with chemotherapy-free strategies. Here are my disclosures, so you can see that I'm consultant for several pharmaceutical companies. My institute receives research grants from many companies, in particular Roche Genentech, which is a company that has developed most of the drugs that I will discuss today. The fascinating story I'm about to tell you starts in 1984 with the discovery of a new oncogene in the laboratory of Robert Weinberg in Boston. The encoded protein called HER2 belongs to the HER2 family of growth factor receptors. There are in total 4 receptors, HER1, HER2, HER3, HER4. And these receptors play a central role in the pathogenesis of several cancers. Upon ligand binding, these receptors undergo dimerization and phosphorylation of their internal portion, intracellular portion. The HER2, HER3 heterodimer is the one with the highest signaling potency. It activates many downstream pathways, in particular the PI3K AKT pathway, which is a master regulator of cell cycle progression and cell survival. And then 3 years later, in 1987, an oncologist from UCLA decides to evaluate HER2 amplification in a series of frozen biobanked breast tumors. And he makes a critical observation. And this is that this genomic aberration is present in 1 out of 5 breast cancers and is associated with a very poor clinical outcome. So most of these women present a relapse and die from breast cancer within 3 to 5 years from diagnosis. And then a collaboration starts between UCLA and the company Genentech, and 5 years later, a humanized anti-HER2 monoclonal antibody is produced. It receives the name trastuzumab. It enters clinical investigation. And at the turn of the century, it's very clear that this drug is a real breakthrough and that it can improve, prolong the survival of women with advanced HER2-positive breast cancer. So the next logical step was to transpose this drug to early HER2-positive breast cancer in order to see if it can prevent the development of metastasis, and that's the story I'm going to tell in the next 20 minutes or so. So as you can easily understand, it is absolutely vital today not to miss the diagnosis of this particular breast cancer subtype. And this responsibility is in the hands of our pathologists. They have to evaluate overexpression of the HER2 receptor using immunohistochemistry or amplification of the HER2 gene using fluorescence in situ hybridization. Now, in the last 20 years, 3 strategies have been explored to improve cure rates of early HER2-positive breast cancer. And as we will see, these strategies are based on the development of 4 targeted HER2 drugs that I will briefly describe to you. So there are 2 anti-HER2 monoclonal antibodies, trastuzumab and pertuzumab. One, a small molecule which inhibits the tyrosine kinase of the HER receptors, and the last one is an antibody-drug conjugate. So very briefly, let us explain how these anti-HER2 drugs antagonize cancer cell proliferation. Well, here you can see in pink trastuzumab, the anti-HER2 monoclonal antibody, which, as you can see, binds to the extracellular portion of the HER2 receptor. It's a transmembrane receptor. And trastuzumab binds to the domain which is closest to the membrane. And by doing that, it will disrupt signaling of this potent HER2, HER3 heterodimer and block signal transduction. The second anti-HER2 monoclonal antibody binds to a different epitope in the extracellular portion of the HER2 receptor. It's, in fact, the domain which is responsible for the dimerization of HER2 with other family members, in particular HER3. And that's the mechanism of action of this second anti-HER2 monoclonal antibody. Neratinib is an irreversible tyrosine kinase inhibitor, so it inhibits the tyrosine kinase, which is in the intracellular portion of the receptors. It binds to HER1, HER2, HER4, and it will block signaling through several homodimers or heterodimers. And last but not least, this is a fascinating drug. It's the first antibody-drug conjugate introduced for treatment of women with breast cancer. It's called trastuzumab DM1. And what you can see is that 3 potent cytotoxic molecules that correspond to a drug called maytansine, which is an inhibitor of microtubule assembly, are linked to the antibody trastuzumab through a non-cleavable linker. And this drug behaves like a Troy horse. So trastuzumab will bind to the HER2 overexpressing cancer cells and not, in principle, to the normal cells. And then this complex will be internalized and the cytotoxic drug will be liberated inside the cancer cells. And so this drug has very few side effects. It's associated with the maximum quality of life. Now here are the 3 successive strategies that we have explored in early HER2-positive breast cancer in order to improve the chance of cure. Because here what we want to do is eradicate micrometastasis. We want to cure the patient. The first strategy has been single HER2 blockade based on the parent drug trastuzumab. The second strategy has been to add a second anti-HER2 drug to trastuzumab. And the third strategy has been to use this interesting Troy horse, and we will see how. So, single HER2 blockade with trastuzumab. You know that in breast cancer we prescribe chemotherapy,   , with the goal to eradicate micrometastasis.
Mm-hmm.
Well, there have been several randomized trials for these women with HER2-positive early breast cancer that have compared chemotherapy alone or chemotherapy with the addition of trastuzumab given in general for 1 year. And all these trials, with only one exception, have clearly shown a significant reduction in the risk of disease relapse when you add trastuzumab to chemotherapy, and also a significant reduction by something like 33 to 59% in the risk of death from breast cancer. And the blue bar represents the trial that was conducted by the Breast International Group, the HERA trial, which gave an early access to European women to this life-saving drug, trastuzumab. Now, there is a small price to pay for this combination of chemotherapy and trastuzumab, and this is a small risk of cardiac insufficiency ranging from 0.5 to 3%. But the good news is that this trastuzumab-induced cardiomyopathy is far less severe than anthracycline-induced cardiomyopathy and is very often reversible. So, the next logical step was, if blocking HER2 with one drug works, probably blocking HER2 with two drugs will work even better. And today there are two dual HER2 blockade strategies that are approved by the FDA and the EMA. And this is the combination of trastuzumab and pertuzumab, the two anti-HER2 monoclonal antibodies, or trastuzumab given for 1 year, followed by neratinib, the small oral molecule also given for 1 year. Now, while we have seen advantages to the use of dual HER2 blockade, we have been a little bit disappointed because the magnitude of the benefit we have seen has been rather modest and in fact confined to women with node-positive disease. So just to show you an example, this is another big trial, Affinity, which compared chemotherapy plus trastuzumab and pertuzumab to chemotherapy plus trastuzumab and placebo. And here you see the 6-year results in terms of disease-free survival. On the left, the node-positive patients. So there you see indeed a 5% reduction in absolute terms in the risk of experiencing a relapse, which is statistically significant and clinically meaningful. But you see for the patients with node-negative disease on the right, no benefit at all. But you can be impressed there by their excellent outcome. So these women with HER2-positive breast cancer, node-negative, have a 95% chance of not experience any relapse in 6 years, the 6 years following surgery. And so it's very difficult to improve upon that. Now, the trials I just discussed with you are adjuvant trials. What this means is that the surgeon resects the tumor in the first place, and then we medical oncologists, we prescribe these expensive and sometimes toxic drugs as blind doctors, because we have no way to evaluate if what we do is helping the patient. And so, starting in 2015, there has been a growing interest in giving these anti-cancer drugs prior to surgery. And this is what we call neoadjuvant medical treatment, which has a big advantage because then you can see if the drugs you are prescribing are shrinking the tumor, and then you can hope that if that's the case, they are probably also efficacious on micrometastasis. So here, we are no longer blind doctors. But there is another interesting feature of this approach, and this is that complete eradication of the tumor at surgery. So no tumor left in the breast and in the nodes. What we call a pathological complete response identifies a group of patients with a very good prognosis, much better than the one of patients with residual disease, which is shown on the right with the curves. And this paradigm shift in the way we treat women with HER2-positive breast cancer has been greatly reinforced with the discovery that there is a drug that can help patients with residual disease. So these patients who have a much worse prognosis, we can do something for them, and this is the introduction of TDM1, of the troyons. And this was elegantly shown in this famous trial, Catherine, where close to 1,500 women with residual disease following neoadjuvant chemotherapy with anti-HER2 drugs were randomized to get either trastuzumab or TDM1. And TDM1 was clearly superior with a 50% reduction in the risk of disease relapse, translating into an 11% better outcome at 3 years. So here we are in 2019 with a complex, expensive, one-shoe-fits-all treatment strategy. So for the women we present with tumor greater than 2 centimeters, we give this preoperative chemotherapy, quite aggressive. Then we give 2 anti-HER2 monoclonal antibodies combined with the taxane. At surgery, if there is a pathological complete response, we can continue with the anti-HER2 antibodies alone. And if there is residual disease, the woman will go on and receive 14 cycles of TDM1. If the tumor also expresses hormone receptors, we will also add endocrine treatment. So this treatment is a treatment that lasts minimum 60 months, maximum 6-7 years. And so we started to think that some women with this disease must be overtreated in this way. And that explains the growing interest in trying to cautiously de-escalate treatment for selected women. So, because the heart can be severely damaged, as I told you, by anthracyclines, this is the first building block that we want to get rid of. And we are close to show that this is possible. Indeed, there has been this elegant Dutch trial that randomized 438 women to receive neoadjuvant chemotherapy regimen without anthracycline or with anthracycline. And they reported identical rates of pathological complete response, quite high, 68%, and identical outcomes at 3 years of follow-up. But look at the confidence interval. It's very broad. It goes from 0.50 to 1.63. So clearly this is not a trial that gives enough confidence and that can lead to a change in clinical practice. So what we are hoping now is that this much larger trial of the big network will, in a few years from now, lead to a change in clinical practice. So in this trial, you see that we are going to recruit more than 1,000 women with relatively small tumors. We do not want to take women with bulky disease because we don't want to put them at risk. These women will receive neoadjuvant chemotherapy without anthracycline and dual HER2 blockade, the 2 antibodies. And if at surgery they show this pathological complete response, they will only continue with the anti-HER2 drugs. But for the trial to be successful, these women with a de-escalation of treatment will have to show an excellent outcome. They will have to show relapse-free survival in excess of 94%. Now, what is interesting too here is that the trial is also making a biological hypothesis that takes into account the molecular heterogeneity of HER2-positive breast cancer that we have discovered in the last decade. So, as you can see here, the hypothesis is that the women who will do very well with this less aggressive treatment are women who have a special subtype of HER2-positive breast cancer called HER2-enriched. What does that mean? So here I try to summarize for you what we have learned in terms of heterogeneity of this disease. So first, of course, you need to make sure that the disease is overexpressing HER2. Then you will have already heterogeneity because in 55% of the cases, the hormone receptor will be there, and in 45% it will not be there. And after that, you can go further in the dissection of the disease. In terms of gene expression, we have seen that there are different subtypes, and the HER2-enriched subtype is the one where the HER2 pathway has the highest activity. Then there is also heterogeneity at the level of DNA, and HER2-positive breast cancers can show PIK3CA mutations, which is bad because it tells you then that the pathway is permanently activated. And finally, very interestingly, there is also heterogeneity in the microenvironment, with a lot of tumor infiltrating lymphocytes in some of these HER2-positive breast cancers and not so much in others. And what we think is that the candidates for chemotherapy-sparing strategies are the women with the HER2-enriched subtype, so this is at the mRNA level, no PIK3CA mutations, and a high TIL infiltration. But of course, this is what we need to demonstrate in the decrescendo study. Is it possible that we could get rid completely of chemotherapy? And I personally think the answer is yes. It's going to be for a small group of patients who have HER2-addicted tumors, where we think that the anti-HER2 targeted drugs will be sufficient because they will do a great job. And here comes the power of molecular imaging that we do not exploit enough in oncology. What we have seen is that by using FDG PET, you can make a distinction in these patients with HER2-addicted tumors, where the tumor disappears after 2 weeks of exposure to anti-HER2 monoclonal antibodies. So this is the case of this patient. After 2 weeks, you can no longer see the primary tumor and the nodes. And this is very different for this other patient, in whom, after 2 weeks, you see absolutely no change. And this observation has been exploited by an elegant trial called FERGAIN. In this trial, 356 women with HER2-positive tumors between 1.5 and 5 centimeters underwent a first FDG PET scan. They were then randomized according to a 1:4 ratio to receive the standard of care, which is chemotherapy and dual HER2 blockade, or dual HER2 blockade alone, without chemotherapy. And then, after 2 cycles, 6 weeks, the FDG PET scan is repeated, and if there is a good response seen on the FDG PET, the patients continue without chemotherapy until surgery. And the interesting observation is that in these women where no chemotherapy was administered, the rate of pathological complete response was 40%, so a little bit smaller than in the control arm, but very interesting. Now we are waiting for the mature results of this study in terms of what will happen in the following years, in terms of disease-free survival. To finish, very quickly, will we make further progress for residual disease patients? And the answer is likely yes, because we are now seeing the emergence of better antibody-drug conjugates than TDM1, and then also because we are going to explore ways to activate the immune system in this disease, as we have done successfully now in triple-negative breast cancer. So here is an antibody-drug conjugate that already showed superior efficacy to TDM1 in advanced HER2-positive breast cancer. It is on the left there, trastuzumab deruxtecan. So what you can see is that the antibody is the same, it's trastuzumab, but you have 8 molecules of a potent cytotoxic drug that are linked to the antibody, and the cytotoxic drug is a topoisomerase 1 inhibitor and is not, like for TDM1, an anti-microtubule. Another difference is the linker. Here, it's a cleavable linker. And that is a disadvantage in terms of side effect profile, because the drug will have bystander effects, but it could potentially be an advantage in case the tumor is heterogeneous in terms of HER2 expression. So the other possible progress will come from the realization that the mechanism of action of trastuzumab and pertuzumab is not just switching off the HER2 circuit. In fact, what has been discovered by basic scientists is that these antibodies work through innate and adaptive immunity. And this is a very nice experiment that tells the whole story. So these are mice injected with an HER2 overexpressing cell line and treated with the rat homologue of the human anti-HER2 monoclonal antibody. And there are three groups of mice. In the wild-type mice, the treatment works beautifully well. Then, in the mice which are knocked out for Fc gamma receptor expression, there are no regression seen. And then, in mice lacking T and B cells, we see limited tumor regression. And so, the way we think trastuzumab operates is shown here. So the antibody is in blue, and you see that it is recognizing the HER2 overexpressing cancer cell, which is in orange. But what the antibody will also do, and that was neglected by us for many years, is that it will recruit Fc receptor gamma expressing cells, like NK cells. So, antibody-dependent cellular cytotoxicity will operate and cause cell death with the release of death signals, such as HMGB1, which will then trigger the activation of antigen-presenting cells, so that at the end, CD8-dependent adaptive anti-tumor immunity will be generated. And so today we think that the immune mechanism of action of trastuzumab is more important than the blockade of the signal that I described at the beginning. And so, what we will see now with clinical trials that are just starting is that for patients who do not have this pathological complete response and who remain at risk of relapse, maybe trastuzumab deruxtecan will be shown to be superior to T-DM1 as a salvage treatment. And there are also clinical trials that are going to look at the addition of an immune checkpoint inhibitor to T-DM1 as a way to further improve results. Okay, I think it's time to conclude. I hope I could demonstrate to you that the development of these elegant targeted drugs against the Achilles heel of this disease, which is the HER2 receptor, has translated into significant improvements in outcome for these women, but also that with these smart targeted drugs, there is now a possibility perhaps for some of these women to completely avoid chemotherapy in the future. So I was very lucky to take part in this journey in the last 2 decades, helped by my team that I would like, of course, to thank today, and I also would like to thank the women who participated in all these important clinical trials. Thank you.
Thank you very much for this amazing lecture that really inspired us, both at the basic and translational level. I cannot abstain myself to say that the original discovery of Bob Weinberg was on rats and on rat receptor that was actually mutated in the membrane domain, but in humans it's the non-mutated gene that is amplified, and that leads to dimerization and activation. So it's amazing that work in rats on mutated receptors. The first antibody was also done against the rat receptor that blocked the new in rats that internalized and destroyed it, and that's what they humanized in Genentech. So that's an example of how research in animals can impact really human health. Questions from the audience?
I have a question from Dominique Bron, that you know very well, from Bordet. She says, merci Martine pour cet exposé très rassurant. Y a-t-il un âge limite pour cette approche, comorbidité qui augmenterait la toxicité des assais conjugués?
Je ne suis pas sûre que j'ai compris tout à fait. Donc,
ouais. Donc, y a-t-il un âge limite pour cette approche et des comorbidités qui augmenteraient la toxicité des assais conjugués?
Bon, je crois que l'âge, certainement, est un facteur de risque pour les effets cardiotoxiques de ces thérapies anti-HER2, ça a été montré. un des facteurs de risque dont on tient compte, et donc on va rarement utiliser effectivement les anthracyclines chez des patients de plus de 65 ans. Maintenant, jusqu'à présent, pour les données qu'on a accumulées avec les antibody drug conjugates, on n'a pas mis en évidence de toxicité plus importante chez les patients âgés. Voilà, mais c'est certainement quelque chose qu'il va falloir surveiller de près, surtout que le cancer du sein est une maladie fréquente et bien sûr fréquente aussi chez les femmes de plus de 65 ans.
Je vais laisser la professeure vous répondre puisqu'elle est avec nous en direct et vous dire si elle a d'autres questions pour vous. Dominique Bron.
Merci Martine. C'est super exposé. C'est vrai que c'est très rassurant de voir l'évolution pour un mauvais cancer du sein. Mais je crois que tu as répondu à ma question, puisqu'on essaye d'aller vers des traitements sans chimiothérapie, parce que le cancer du sein touche quand même des gens de plus en plus âgés aussi. Et je ne sais pas si, en dehors de la chimiothérapie et de l'anti-HER2, est-ce que le fait qu'il soit conjugué à un dérivé neurotoxique, ça vous pose des problèmes?
Mais je crois que ça, c'est toute la beauté de la chimie qui est derrière ces antibody drug conjugates, qui ne seront pas tous égaux. Je pense que certaines firmes vont développer des molécules plus performantes que d'autres en s'attachant à toutes sortes de petits détails qui sont très très importants, comme par exemple la qualité de la liaison entre l'anticorps et la molécule cytotoxique. Et puis la molécule cytotoxique en elle-même va évidemment être très importante. Donc voilà, je pense simplement qu'il y a dans 10-15 ans, on ne va plus prescrire de chimiothérapie. C'est mon rêve. Je pense qu'on aura plein d'antibody drug conjugates. Je ne dis pas que ces molécules sont parfaites, parce que vous avez vu que si le lien est clivable, malgré tout, il y a une toxicité qui peut se manifester, mais ce sera quand même une manière incroyablement plus élégante d'essayer de traiter les cancers que par la chimiothérapie libre telle qu'elle est utilisée aujourd'hui.
Merci à toutes les deux. D'autres questions dans la salle?
I will make a comment. Interestingly enough, this antibody, when it enters the cell, will go to endosomes and then lysosomes. Now, as a function of the pH and the quality of the linker, some of the payloads would be released and some will not. Some, therefore, will recycle back, or some will get into the cytoplasm and then to the nucleus. So I think there's a lot of potential in actually varying the linker and the payload. So you're going to see that also for other antibodies.
Yeah, I think I read that there are more than 100 antibody drug conjugates now in trials in different diseases, not only breast cancer, of course. Yeah.
So one question I had was, there was some cardiotoxicity, as you know very well, for anti-HER2. Do you know if when you couple it with different things and different antibodies have different levels of cardiotoxicity, it's just the trastuzumab that has it, or also all of them?
Well, for example, pertuzumab also has some cardiotoxicity, but what was very reassuring was that when we used the two drugs together, we were nervous. We thought perhaps the cardiotoxicity will increase, and it's minimally increased to a non-significant degree, which was very reassuring.
It's very nice. It's wonderful.
Merci, professeur Piccard.